Okay, well, I see a number of people joining in. I don't want to punish those of you who are on time, so we're going to get started. And I expect a few more of us to be calling in the next few minutes. So good afternoon, everyone. Thank you for coming. My name is Matt Harris. I'm Vice President of ASSP Long Island Chapter. I want to thank everyone for joining us and welcome you to our first virtual meeting of the new chapter year. I'm excited for this upcoming year. We have plans for a variety of safety topics to be presented, which will hopefully include some in-person get-togethers and field trips as the year progresses, so stay tuned. I do see some new faces and names on the call, so for any first-timers, welcome. Be sure to visit our website at li.assp.org for details about our organization, including upcoming events. And I'll actually just take this opportunity real quick to plug our November technical meeting. That'll be November 10th, which is a Wednesday. We'll have a lunchtime meeting from 12 to 1 p.m. with presenter Abby Ferry, who quite literally wrote the book on habit forming safety training. And she'll be joining us to talk on that topic. So we're going to get right into our presentation for today. We're very lucky to have joining us Mr. Evan Rousseau, Director of Industrial Hygiene and Workforce Safety for Northwell Health. Evan is a Certified Industrial Hygienist, CSP, and OSHA Authorized trainer. He holds a Master's in Public Health, an MS in Information Systems, and BA in Chemistry. Evan served in the U.S. Army and Army Reserves and has IH experience working for Montefiore Medical Center and the Albert Einstein College of Medicine. As seen from today's presentation title, Evan will be talking to us today about his field of industrial hygiene and its applications in the healthcare industry. Now, this is a unique field which considers patient, staff, and visitor safety, and according to Evan, requires extensive collaboration between diverse groups of professionals in order to minimize and mitigate potential hazards. So I'll give it right over to Evan now. Evan, thanks again for being with us today, and whenever you're ready.
Okay, so good afternoon, everyone. Once again, my name is Evan Rousseau, one of the directors in the Workforce Safety Department at Northwell Health. We are a health system of 23 hospitals throughout mostly Long Island, but we also have locations in Lenox Hill and Manhattan, hospitals, Forest Hills and Queens, 2 hospitals in Staten Island, and Northern Westchester Hospital in Phelps in Westchester County. We have approximately 70,000 team members throughout our 23 hospitals and 800 ambulatory locations. And within my team, I have a team of 11 safety professionals. So, okay. Matt, thank you, Matt. You can skip that slide. And of course, I just want to say that the views of this presentation are my own and do not reflect the views of Northwell Health. Okay, and Matt gave you basically my background and my experience within the safety field. All in all, coming up, it's past 20 years now. So 20 years within the safety field. So here's what I have for the agenda for this afternoon's conversation. So I'm going to give a very brief introduction to industrial hygiene to those of us who are unfamiliar with the field or just need a quick refresher. But the main focus of this discussion is going to be how industrial hygiene is applied in the healthcare setting. I'm definitely the first off the bat. I'm going to speak about the elephant in the room, SARS-CoV-2 or aka COVID-19. Followed by, we're going to have a discussion about hazardous drugs and how industrial hygiene is applied in that field. Infection control risk assessments when it comes to construction activities. Hospitals are constantly renovating and remodeling themselves. So, but that construction activity poses risk to our patients and visitors. So we do have to do risk assessments to mitigate those hazards. And lastly, we're going to discuss the numerous types of occupational exposures to our team members in their healthcare setting. It's not an exhaustive list, but the most prominent ones that we in the industrial hygiene field have to face. And lastly, summary. So again, what is industrial hygiene? And it's the art and science of anticipating, recognizing, and evaluating evaluating and controlling potential workplace hazards. And we say it's an art because there's no one approach to solving a problem, and there's no cookie cutter approach. So creativity and resourcefulness come to play. And it's a science because we have to use the principles of engineering, toxicology, chemistry to help solve the problems that the hazards that we come across. Next slide, please. So, how industrial hygiene applies in healthcare. One of the unique facets of healthcare are the number of authority-having jurisdictions that healthcare has to abide by. So the first one is the Joint Commission, and that body evaluates and provides accreditations to the hospital. Every 3 years, a particular hospital has to go through the accreditation process, and it's a 4-day process. It's a 4-day process where the Joint Commission reviews documentations such as our environment of care, emergency management, and numerous other facets. So that we're maintaining the highest standards of medical care. The other organization is, of course, OSHA under the general industry standards. So we have to abide by the bloodborne pathogen standard, respiratory protection, which played a big part during this pandemic, hazard communications, which also played and continues to play a big part, and personal protective equipment. Again, this is not an exhaustive list of items that we need to abide by within the healthcare field. Just a small sample. But with the Joint Commission, where industrial hygiene falls is that one of the things that the Joint Commission looks for is, are we evaluating chemical hazards within the workspace? Are we monitoring for waste anesthetic gases? Are we monitoring for any of the disinfectants, the high-level disinfectants that we use to disinfect equipment? But are we monitoring to make sure that they're not having an adverse effect on our team members? Next slide, please. And then we have ACGIH, the American Conference of Governmental Industrial Hygienists, and NIOSH, the National Institute of Occupational Safety and Health, which also provide us direction and guidance on chemical and physical hazards within the healthcare setting, especially for those items where OSHA does not have an occupational exposure limit. Then we defer to the ACGIH or NIOSH, and I'll definitely speak more of those on those items once we get to the occupational exposures section. Continuing on with authority having jurisdictions, the Centers for Disease Control and Prevention. And through the CDC, they provide us resources that assist us as healthcare workers in assessing and reducing risk infectious diseases, not only to our patients, but also to our team members. And here the CDC, within the last 18 months, has provided us with a plethora of guidance throughout this pandemic when it relates to PPE, respiratory protection. How do we maintain social distancing within our facilities, and how do we interpret that those numbers? Remember, we've all heard maintain 6 feet distance, but what does that actually mean when you're in a room or you're in a space and you're trying to come up with, hey, how much space do I have to maintain between people? How many people can I occupy in a certain square footage of room? So all of these interpretations had to be performed by our industrial hygiene team throughout the and we still continue to do those interpretations throughout the pandemic. Next slide. So continuing on with other standards and guidelines. So we have the ASHRAE, the American Society of Heating, Refrigeration, and Air Conditioning Engineers. They put out guidance on ventilation, and one specifically, ASHRAE 170, ventilation of healthcare facilities. That really dictates, how much ventilation do we have to provide at a minimum for each of these certain locations within the hospital, within a hospital. So, for example, an operating room has to have a minimum, according to the 2019 version of ASHRAE 170, minimum of 20 air exchangers per hour. And another example, a newborn intensive care unit, again, would have a reduced number of air exchanges, six air exchanges per hour. But in both cases, they must be maintained under positive pressure, and no air recirculation is allowed in those cases. So again, these are the things that all of healthcare has to abide by, and there are more. So we have the National Fire Protection Association, NFPA. There's one specifically just for healthcare, NFPA 99, and there's another NFPA 101, the Life Safety Code. So again, there are quite a bit more of these authority having jurisdictions that healthcare has to abide by, and it makes safety and industrial hygiene that much more challenging. Next slide, please. So let's talk about the elephant in the room, right? So the last 18 months, the U.S. and the world has been battling SARS-CoV-2, aka COVID-19. And I really have to congratulate the safety officers, the infection prevention specialists, and the industrial hygienists, because we showed our true value during this pandemic. The skill sets that we have when it comes to respiratory protection and evaluation, hazard communications, such as the EPA approved disinfectants for COVID-19, and conducting those workplace risk assessments as it relates to social distancing and occupancy levels, greatly reduced the transmissibility of this disease, and ultimately will lead to the end of this. Of this pandemic. When we were evaluating the social distancing and occupancy requirements, 6 feet. We ended up with a rule of thumb, basically saying we could give provided that the room had MERV 13 filters, which all of our facilities do. 36 square feet became the rule of thumb per person, the rule of thumb when determining occupancy for a location. But that 36 square feet had to be 36 square feet of actual space, unencumbered by furniture, chairs, and other items. So that was our rule of thumb when making those occupancy determinations. So During the pandemic, we had several regulatory bodies pay us a visit. And the regulatory response during this pandemic was mostly from OSHA, and late into the game, we received some regulatory information from New York State. Initially, there was no COVID ETS, no COVID standard. And even the bloodborne pathogen standard, the OSHA bloodborne pathogen standard, did not really apply in this situation. So OSHA used the general duty clause. And and if we remember, the general duty clause is the catch-all if there's a hazard present that the employer has to provide some type of corrective action. So we did get several inquiries from OSHA regarding respiratory protection and personal protective equipment. Later on, OSHA did release more information in March of 2021. They had a national emphasis program, which really targeted the highest risk occupations, which were healthcare and the meat industry, where again, OSHA provided some guidance as to guidance on respiratory protection, PPE, and work practices, how to stagger work practices, recommendations on social distancing, and other administrative controls, again, all geared to reduce transmissibility. Then we had the emergency temporary standard, the subpart U, from OSHA, and that came in June of 2021. And with an emergency temporary standard, it is designed to last up to 6 months. So if this does not get extended, we may see that this standard may disappear by December. But knowing our regulatory agencies, that the pandemic is still here, this may be extended or be modified in some form, but I do not have any direct information on that. But the OSHA subpart U COVID emergency temporary standard did have some very important parts within that standard, and one of them was to train our team members. So we had to train on what the disease is itself, how it's transmitted, risk factors, how do we manage, how do we screen our patients, and how do we screen our employees, cleaning and disinfection, and most importantly, an anti-retaliation clause within that standard. So the employer cannot retaliate against an employee who's genuinely concerned about their safety. And I found that that portion of the ETS was, for the most part, well written. There, of course, we did have our comment period during the creation of the standard, but for the most part, well written. So the next portion in the regulatory phase came through New York State, and the New York State Health and Essential Rights Act, or what we call now the HEROES Act. And the HEROES Act, this was signed into law in May 5th of 2021, and it was activated by the by the governor in September 6th of 2021. And this, when activating this, it has to be activated for specific airborne infectious disease by the health commissioner of the state. And very similar to the OSHA subpart U COVID-19 ETS, it required very similar training requirements. But the slight difference in this standard was that when an employee makes a complaint to an employer, it gives a specific time frame that that it has to be addressed within, and it has to be addressed within 30 days. Um, the the HEROES Act also, it does not apply to the seasonal flu. So it has to be it has to be enacted by the whatever the agent may be. It has to be enacted by the Commissioner of Health of New York State. So next slide, please. Oh, I'm sorry. Go back one more. Go back to the previous slide. Yeah, I just really wanted to, no, right there, that's fine. So I really wanted to speak about this because during the pandemic here and the issue of respiratory protection, our N95 respirators. So as with everyone else, we were constrained with the supply of N95 respirators throughout the pandemic. And I have to say that we've had some less than let's say candid characters provide us with try to sell us knockoff N95 respirators, and what we ended up doing was basically sticking to our vendors that we've always worked with, 3M, Halyard, Kimberly-Clark, Cardinal Health, and getting those respirators. And what we also did is that we supplemented those respirators with elastomeric half-face respirators, where we've trained our team members on how to place those respirators on and how to maintain those respirators, and that's been a very successful program. We've also had to increase the number of powered air purifying respirators that we've had to use throughout the health system, like we've never seen before. We have had, PAPRs every now and then throughout the health system, but once the pandemic hit, we were getting more and more requests and accommodations for those type of respirators, and we were successful in getting a quite decent supply of those respirators. But we really had to make sure that team member really needed that respirator. So we had a tiered approach of providing that respiratory protection. So first we started off with N95 respirators, where we had several different sizes and models that the team member could fit on. If that didn't work, we moved up to the half-face respirator. And if that didn't work, then they received the PAPR. And when we fit tested our team members, we fit tested them with depending on the case, with both the Bitrix solution and or the Porter counter. There were some cases where for medical accommodations and religious obligations where team members had to wear their facial hair. So they basically were able to get the PAPR respirators. And again, that practice has been successful for us at Northwell Health. Next slide, please. So hazardous drugs. So this is something that's relatively new for us as industrial hygienists. But back in 2011, there was a letter created by OSHA, NIOSH, and the Joint Commission raising their concern for healthcare workers and exposure to hazardous drugs. These drugs have been known to cause cancer, have reproductive and development problems for unborn fetuses, and allergic reactions. Next slide, please. And the best way to control it is to use our tried and true methods of industrial hygiene, using the hierarchy of controls. So, for example, under engineering controls, negative pressure rules, and biosafety cabinets. Under our administrative controls, limiting access to drug preparation areas in the pharmacy, extensive training on work practices and the use of personal protective equipment in the form of gloves, gowns, and N95 and N95 respirators. And those gloves, especially when we're working with hazardous drugs, had to meet the specific ASTM requirement for chemotherapeutic drugs, and those gloves had to be changed every 30 minutes. Next slide. Again, medical surveillance. So this is something not something new to industrial hygienists of medical surveillance, but in the case of hazardous drugs, the medical surveillance requirements were they were, I would say, nebulous. With other OSHA standards that require medical surveillance, such as the hearing conservation, the occupational exposure to noise, where you do audiometric testing. For formaldehyde overexposures, you have a medical surveillance program. For benzene exposures, you have a medical surveillance program. And for asbestos, you have a medical surveillance program. And all of those programs are very clear, or basically pre-designed and clean cut for you to use. But with hazardous drugs, it wasn't so clear. And it really, this is where the occupational physician and industrial hygienist work together. First with the industrial hygienist identifying the need for via risk assessments, identifying the need for a medical surveillance program, and then the physician having to design a medical surveillance program. So in the case of hazardous drugs, it's really going to be the medical surveillance program. It's going to be really drug specific to design that program, where it's going to be taking into account work history, reproductive questionnaire, how long that the team member has been working with hazardous drugs, and baseline blood cell counts to help design that medical surveillance program. But the main effort goes into the hierarchy of controls, where we stress the engineering, administrative, and personal protective equipment. Next slide. Okay, and of course, record keeping. We have to maintain our records for quite a few number of years. And lastly, periodic review to adopt any new guidelines, and to evaluate our policies on an annual basis to make sure that they're doing what they were designed to do. Okay, next slide, please. Now, like I mentioned earlier, hospitals are always going under some type of renovation. A new wing may be being added. Another wing may be being demoed and being remodeled. But during that process, infection control risk assessment must be done. It's also, in certain locations, it's also called a pre-construction risk assessment or infection control risk assessment. They both mean the same thing, but it's a process that identifies the risk associated with construction or maintenance activity, and it dictates what mitigation strategies are going to take place to minimize hospital acquired infections to our patients and to our patients, and our employees, and our visitors. And what makes hospital construction different than other type of construction is that, hospitals can't shut down. There's it's 24 hours a day, 7 days a week. We have immune compromised patients. Medical staff are in the vicinity, and the pace of work on the construction is typically faster, where we want the project to get done as fast but as safe as possible. Next slide, please. So how is this risk assessment performed? Well, it's performed by a multidisciplinary team that includes construction managers, infection control specialists, safety professionals such as industrial hygienists, and the clinical staff where the work is going to impact. And when we say that the work is going to impact, not just only the construction site itself, but adjacent locations to the sides and above and below that construction site may be impacted. And all of these stakeholders go through the process of drawing up the mitigation practices that will be done for that job. And this process must be documented and signed so that all stakeholders are aware of their responsibilities throughout the entire process. And let's go to the next slide. And just want to discuss that the infection control risk assessment is designed to break the chain of infection. And this chain of infection is what this photo to the right displays, is that if all these links are connected, there's a possibility that an infection can take place to one of our patients. But what the infection control risk assessment is designed to do is to break that chain of infection so that infections do not spread as a result of construction activities. So I just want to give a few examples. So for instance, potential pathogen and may be aspergillus, and that's a fungus that may be in the reservoir of a old ceiling tile. And disturbing that ceiling tile may make that aspergillus airborne. And transmissions, how things are transmitted, they could be either airborne, contact, or waterborne. Portal entry, that could be an open wound, and we may have a susceptible host. So that chain of infection, if it's continuous, we can potentially infect a patient. But what we want to use the infection control risk assessment is to break that chain of infection so that those infections do not take place within the healthcare setting. Next slide. And as with the authority having jurisdictions within the healthcare system, we have other authority having jurisdictions when it comes to the infection control risk assessment. So the Facilities Guideline Institute, the Joint Commission, the Centers of Disease Control, the American Institute of Architects, and with internal organizational policies, all dictate that an infection control risk assessment must take place within the healthcare setting. Next slide. Factors. So risk factors that have to be included when conducting this risk assessment, really three main factors that'll come up with your risk mitigation matrix. So you have your occupancy risk groups, right? And some of them are really low risk, which we consider risk level 1, to our highest risk patients, such as the immune compromised patients, chemotherapy patients. Those would be classified as your risk 4 patients. And then the type of construction activity. So here at Northwell, we classify our construction activities as either type A through type G. The most the least invasive to the most invasive, and of course their impact on clinical services. And with this, matching the occupancy risk group and the type of construction activity will determine our mitigation strategy. And again, all of these all of this is conducted with that interdisciplinary group. All these activities are documented, and once that mitigation strategy is selected upon, the infection control risk assessment document is posted right at the job site, so that any inspector or anyone within the hospital can take a look at this to make sure to confirm that we're following our own internal policies and those by those authority having jurisdictions. Next slide, please. So the main mitigation strategies are going to be isolation and containment, hard barrier walls, negative pressure. We want to make sure we maintain negative pressure within the workspace. 0.01 inches of water, and of course cleaning, meticulous cleaning. So you'll see HEPA vacuums. You'll see stick-off maps, and also a verification of whether those practices are working. So you'll see measuring the negative pressure. You'll see a manometer outside the outside of the workspace, making sure that negative pressure is being maintained. You may see someone walk around with a real-time particle counter, measuring particles outside of the work area, making sure that they don't go above the previous week's baseline particle counts before construction took place. And again, all of these practices are designed to reduce dust and the infection. Reduce dust and the possibility of any hospital-acquired infections due to construction activities. Next slide, please. And the last major topic that I'm going to discuss this afternoon, occupational exposures. And again, this is not an exhaustive list, but just a sample of what we have, what we're faced with in the healthcare setting. So one, nitrous oxide, and this is our main exposure group. It would be the dental team, and here at Northwell we have three main dental units. There are no OSHA permissible exposure limits when it comes to nitrous oxide, but we do follow the NIOSH and ACGIH exposure limits when it comes to nitrous oxide, and we follow the lowest one of 25 parts per million for the NIOSH REL. Oh, I will fix that slide. I just noticed that there's a typo there. I will take care of that. And our control methods, are the local exhaust ventilation via the scavenging system and the general exhaust ventilation within the space. From a previous incident, one of the main issues with nitrous oxide, making sure we don't go above any recommended exposure limit, is proper sizing of the mask on the patient's face, so that we don't have excess gas being expelled outside of the mask. So especially with children, we got to make sure that having the correct children size mask for them, so that again we don't spill nitrous oxide into the ambient air. Preventive maintenance, how's that taking? That gets conducted, especially with the portable units, making sure that gauges are working properly, making sure flow meters are working, and also inspecting of tubes to make sure there aren't any cracks in those tubes. Next slide, please. Halogenated anesthetic gases. This is again the exposure group here will be the surgical team. The main anesthetic gases that are being used today are isoflurane, desflurane, and sevoflurane. Again, these have no occupational exposure limits, and how we control them are local exhaust ventilation via the anesthesia delivery systems and general exhaust ventilation. There is some history behind these proposed exposure limits starting back in 1977, and we don't have anything authoritative yet, but by as of 2020, ACGIH has been looking at isoflurane and establishing a threshold limit value for isoflurane, and sevoflurane is also being looked at, so we can have some type of occupational exposure limit to those. Next slide, please. NIOSH also in 2007 also provided some additional guidance on waste anesthetic gases within the healthcare setting, and it was designed to increase awareness of these waste anesthetic gases, recommended work practices, and ways to identify leaks within the tubing. But again, at that time, there was no occupational exposure limit provided for those waste anesthetic for those anesthetic gases that are currently being used today. Next slide, please. For our morgue and pathology team members, we have formaldehyde that we have to monitor on an annual basis. It's used as a preservative for specimens for examination by our pathology assistants, and we have several exposure limits from OSHA regarding formaldehyde, and it also has a medical surveillance program. And the main controls here are our pathology workstations, which looks very similar to a fume hood, and the general exhaust ventilation within the pathology lab. Next slide, please. Ethylene oxide. This was a sterile. Let me backtrack. So the exposure group would be the central sterilization team, and it was used to sterilize medical equipment that could not be exposed to steam or any other disinfectant. OSHA does have, again, similar to formaldehyde, several occupational exposure limits for ethylene oxide, and the controls were, isolation using the sterilization table, alarm systems that'll detect leaks of ethylene oxide, and of course general exhaust ventilation, and after the sterilization process, any excess ethylene oxide had to be burnt off and something what we called an abater. Good thing for us, we finally got rid of our last ethylene oxide sterilizer in May of this year. So this item is something that we no longer have to worry about. Next, please. Surgical smoke. So here we have the exposure group will be the surgical team, and they may be exposed to a variety of organic and volatile organic and aldehydes during surgeries. And this is mainly due through the use of laser or electro surgical devices that are very hot at the tip to cauterize wounds, but they could release a variety of volatile organic compounds such as and aldehydes such as benzene, toluene, acetonitrile, styrene, formaldehyde, and aldehydes. And in this case, how we control for those hazards is to use a smoke evacuator, and that provided local exhaust ventilation to capture those organic vapors and aldehydes. General ventilation within the OR, and Lastly, we did still need respiratory protection because we still generated some particulate matter within the surgical space. With the smoke evacuators, you really have to follow the manufacturer's recommendations on the filter changes, because at least with the models that we use, every 25 hours those filters had to be discarded and and uh, uh, and and changed. Next slide, please. Noise. So this doesn't go away. So our exposure groups ended up being our engineering team and our helicopter flight group. So with hospitals, we need to have redundant power systems. So emergency generators are always being checked and double checked. But some of our locations have boiler rooms, which are terribly noisy. Which we have to provide a hearing conservation plan for a certain number of our sites. We don't want our team members to have any short or long-term hearing loss. And this is done by isolation, audiometric testing, and of course, personal protective equipment. Okay, next slide, please. Ultraviolet light has come to the forefront again. It sort of went away for a while, but now it's back because of the pandemic. But our exposure groups in this case will be our environmental services team members and our engineering team members. Exposure to ultraviolet light can lead to eye and skin damage, and if you're not careful, especially if you're not vetting your equipment properly, certain UVCs, that range of UV light can generate ozone. We've had a couple instances here where we've had to turn back vendors because their products were generating ozone. So some of the controls here are to use to really do your research and get those non-ozone generating bulbs. Typically the mercury bulbs. Whenever you're using these UV light systems, access has to be severely limited during use, and of course, personal protecting equipment and the eye and face protection. Next slide. Oh, I believe we've come to the, at least right now, come to the end. Industrial hygienists are in healthcare. Again, we're faced with a diverse set of challenges. Not that you get to see, especially when I worked in the chemical industry, or even where I worked in academic medical school. It does require an interdisciplinary team, a cooperative team, so that we could protect our team members. So I work closely with our engineering staff, our construction safety, our infection prevention, our employee health services. We all have to work together to help protect our team members and our patients, because that's the only way we can do it, is by working together. And at its heart, industrial hygiene seeks to anticipate, recognize, and evaluate workplace controls. And again, we do our best to make it a safer workplace. Again, like I said today, this was not an exhaustive list. We still deal with some of the same industrial hygiene issues and safety issues as everyone else. Fall hazards, indoor air quality, healthcare. We're notorious for slip, trip, and falls, especially this time of the year when the leaves are falling and lead to slip, trip, and fall incidents within our facility. So yes, we still deal with some of those issues. It's just that healthcare just makes it a little bit more challenging. So let's see. If anyone next slide, please. So I did put together some of the references that I used to put together this presentation. Next slide, please. There is a very interesting story. I wish I had more time. Maybe I'll do another presentation just on waste anesthetic gases. There is a very interesting story about how the NIOSH, OSHA, ACGIH have been working since 1977 to put together exposure limits. And I'll talk with Matt later on, see if anyone's interested in that type of a presentation. Next slide, please. My contact information is here. The best way to contact me is via email or call me on the cell phone. We're typically always on my team and myself, we're typically on the go, but we do our best to respond to questions as much as we can. Okay. If there are any questions, we still have a few minutes, it looks like. If there are any questions, please, please ask.
Yeah, Evan, thank you so much for that presentation. Thanks for sharing your expertise and knowledge with us.
No problem at all. No problem. I'm still learning myself. I'm always learning.
Absolutely. Well, yeah.
Thanks, Evan. I appreciate it.
Thanks, Bill.
No problem, Mr. Dempsey.
Yeah, I want to encourage anyone to unmute if you have any questions, or type a question into the chat. We can read it out for everyone. Maybe I could just start things off. So Evan, just going back to COVID, if you don't mind. You mentioned the HERO Act. You mentioned all of these rapidly evolving federal mandates. You have state mandates, along with guidance on COVID-19 workplace safety. So do you think maybe you could just for a minute or two provide any suggestions or lessons learned on how your team managed this incredibly dynamic environment during this time?
So our team, I was lucky enough to have the right team members at the right time. So what we did, especially with the training portion of it, both the OSHA ETS and the HERO Act required extensive training. So imagine trying to send out training to 70,000 people. And the only way to do that is through a learning management system. So on my team, I had a person who could create the training. Then I had another person who could load it up to the learning management system. And I had a friend in HR who could give me the names of 70,000 people so to enroll them. So it really was trying, but we actually pulled it off. We're doing something similar at a smaller scale with the HEROES Act, because the HEROES Act actually targets non-healthcare facilities. It's more the administrative personnel. So it's going to be more for us, more like 9,000 people that we have to train. A lot of the material overlapped between the OSHA ETS and the HERO Act, but we got to do what the feds tell us we have to do. So, but I was fortunate to have the right team members and the right people on my team so that we could get it accomplished.
All right, thank you. I appreciate that. And also, we would love to have you come back for the waste anesthetic gas talk as well. So.
Okay, I'll put something together for you. It's a pretty interesting story.
Absolutely.
Evolving story.
All right. Anybody else before we close out?
Yeah. So let me just say, when selecting respiratory protection, just make sure that we're fit testing the people out there properly. I see people, facial hair, goatees that are way too long to be properly fit testing people with N95 half face or full face respirators. Because remember, it is their safety that we're trying to try to help them with. And if you know, we could give them the right PPE, we could give them the right training, but if they don't do on their part, making sure that facial hair is not there, it's not really, it's not providing the best protection that it could.
All right. Well, Evan, thank you again for your time. We really appreciate it.
No problem at all. No problem at all. Like I said, my email is there. There was a typo in the slides. I'll send Matt the edited version so that everyone could have the correct information.
Thank you. And we will be sharing this video to our website as well for anybody who missed. So feel free to share that video. All right. Thanks again, Evan.
Thank you. And thanks everyone for listening to this presentation. I really appreciate it.
Thanks everyone for calling in.
Evan.
All right. Thanks, Bill.
All right. I'll see you later.
All right. As always.
Good job, man.
All right. Have a good night, everyone.
All right. Take care and be well. Take care. Good night, everyone. And remember, be safe out there.